Hello, everyone. Thank you also for inviting me to tell you something about GnRH agonists and how we deal with them in pediatrics. So, as you know already, GnRH is secreted by the hypothalamus and acting on the pituitary, and it's the pulsatile effect that causes the release of LH and FSH, and then the gonads will react on that with pubertal hormones. And when we use GnRH agonists, they constitutively activate the receptors at the pituitary, and this seizes actually this stimulatory and pulsatile secretion, and therefore the gonads will not produce any pubertal hormones anymore. GnRH agonists are not at all a new therapy in contrast to what we might expect from the program, but what has happened is that the legislation around prescribing GnRH agonist has recently changed. Since September 22, it has moved from the category 4 to category 1, which means that in category 4 you needed a medical attestation, whereas now every specialist doctor, so pediatricians in this case, can prescribe a GnRH agonist, and then the GP can continue with the medication. And so we thought that this was a good opportunity to remind you about the use of GnRH agonists in pediatric endocrinology. And classically, we use it for the treatment of CPP, central precocious puberty, but we can also think of using it for growth promotion, for example, and it's increasingly used in the context of transgender healthcare. So the first and most typical use is for the treatment of CPP. So of course we know already all about the diagnostics of CPP, so I'm not going into that. But what we should be well aware of is that we only use GnRH agonists when there is really a documented progression of the CPP. Because many individuals with CPP, especially in the more idiopathic forms, they have also a slowly progressing form or sometimes even a non-progressive form. So it's very important to monitor all these physical signs of puberty over a period of 3 to 6 months' time before you decide to treat with a GnRH agonist. Of course, if there is a very advanced presentation, you might go a bit faster. And then this has also been explained already by Caroline. It is well known that the age of B2, of the standard stage B2, has declined worldwide in the past 40 years, but there was no secular trend in the rise in pubertal gonadotropins or in estrogen concentrations, and the age of menarche has remained constant over the past 30 years. So this means that actually the time gap between start of puberty or B2 and then the start of menarche, this has increased in the past decades. And so this suggests that actually this is more like an independent of the activation of the APG axis, so rather premature telarche than CPP. And there are various reasons for that, which I'm not going to detail right now. But this means also that we should not every time that we see a girl with B2 immediately think about treatment with GnRH agonists. One can also ask the question, what would you actually use GnRH agonists for? What is in most cases, not of course the pathological cases where you have MRI abnormalities or other findings, but in most cases this is just a variation of physiological puberty. It's not really a disease, it's not a health-threatening condition, and the most often mentioned reasons are that you want to secure adult height, that there is a kind of non-acceptance of menarche at an early age, and that CPP can lead to psychological difficulties. And we know that if CPP starts very early, before the age of 6 years, then it's true indeed that with treating it, blocking with GnRH agonists, then this will increase your final height with 9 to 10 centimeters. So that's really a very good reason, of course, to start. However, we should be aware that if you start after when CPP starts after the age of 8 years, that there is no effect on final height anymore. So then this is no reason to start the GnRH agonist. And between the age of 6 and 8 years old, the studies are a little bit conflicting, and it's not really clear if you have some effect on your final height or not. Many parents, especially if girls have, for example, a developmental delay or cognitive deficiency, then they are a little bit afraid of these menarche and having regular periods, and ask sometimes to block the puberty. But we can always think in these circumstances also about alternative treatments, for example, the use of an intrauterine device, for example, and some of them have typically been designed for young adolescent girls, women. This is actually probably a more non-invasive and more physiological treatment than blocking puberty for many years in these girls. Can be placed under anesthesia, for example. And then also we know that if you have CPP, this may be associated with psychological adaptation difficulties. However, there is no study that shows that if you give GnRH agonists, that this will really improve the psychosocial functioning of the child. So overall, one should say like GnRH agonists can, of course, very efficiently treat CPP, but it's very important to discuss this with the family and most importantly with the girl herself, because most often these are girls, and that the decision is really made on a case-by-case basis. It's like a shared decision-making process that you would need to start. On the other hand, we must also recognize that GnRH agonist is actually a very safe treatment in this context. And we know that menses will resume spontaneously after the stop of GnRH agonists at a mean of 16 months after stopping this. There is no impact on the BMI, there is no increased risk for PCO, no impact on fertility, on reproductive lifespan. There is a decrease in BMD, but it will show some catch-up again, and actually the peak bone mass will be similar as in controls. There is no impact on psychological functioning, no long-term impact on cognitive functioning, and so on. So overall, very safe treatment, so that's also very important, of course. Then let's go to the concept of using GnRH agonists for growth promotion. I've already explained that if CPP starts very early, then it will impact your final height if you use GnRH agonists. But in general, that's not the case. And so it will probably not be very effective for growth promotion. But if you consider a study where you do growth hormone together with GnRH agonists, this may be more effective than just using growth hormone alone. And this is exactly what we did under the coordination of Hilde Dotremont. We did with BESPEED a study which was very recently published in Frontiers in Endocrinology, where we treated 24 early pubertal girls with a short predicted adult height. They were all M2, M3, and they received for a period of 4 years GnRH agonist plus growth hormone. And it was a very nicely conducted study where we looked also at control data and where we saw that actually the mean height SDS and the mean height SDS minus the target height SDS, it became closer to 0 over the years that the treatment lasted, and that in the end it swept around in the treated group. And so the mean adult height of the treated group was 6.4 centimeters taller than the control group and 12 centimeters more than their predicted adult height. There was one drug-related serious adverse event, or presumably drug-related, which was a fracture of a metatarsal. But importantly, this study had a very high dropout rate, and actually 1 out of 3 participants dropped out. A lot of boys also dropped out, and this caused that we could not even analyze the data on the boys and had to exclude them from further analysis. And why is this? Well, it was a very heavy psychological burden for all these adolescents to continue blocking puberty until 16 years of age, or using this for many, many years before you could go puberty start. And so, in conclusion, it's a very effective treatment, but it comes with a high psychological and also financial burden, and therefore it's not, well, certainly not advised as a general treatment for growth promotion. And then, as I said, GnRH agonists are increasingly used in the context of transgender healthcare. And it also receives increasing criticism for that. And I will try to explain you a little bit why this is. If we look at the Endocrine Society guidelines of 2017, it says that where indicated, we should use GnRH agonists to suppress the pubertal hormones of transgender youth. And nonetheless, we see that if we look really at the numbers of those individuals who will use these GnRH agonists, these are quite limited. This is data from our child gender clinic in Gent. So of 1,048 minors who presented over the period of 15 years, there were 490 who started with medical treatment, and only 88 got the GnRH agonist decapeptyl for a while, as was started at a mean age of 12 years. Is it because of safety data? No, not really. I will show you. There have been a lot of studies done on short-term outcome and safety of use of GnRH agonists. And recently also our PhD student Sylvia Piancia did some very nice studies. Here you see the growth pattern under the use of GnRH agonists, which was started very early in puberty, and that's where our study differs from the most of the published studies. Usually they are started at age 15 or so, when puberty is already ongoing. Usually when we use it, we start it at very early puberty, so Tanner stages M2, M3, G2, G3, and it was continued for a period of over 2.5 years. Most of the adolescents were treated for 3 or 4 years before adding gender-affirming hormones. And here you see the evolution of the height Z-scores according to the sex registered at birth. And you see that for the trans boys, this remains more or less constant. The Z-scores decrease in the trans girls, but then when starting gender-affirming hormones, there is a kind of catch-up growth, and you will end up with a Z-score which is close to 0. Most of the height gain, although, is realized during the use of GnRH analogs, which is the light, the paler bars, and then the number of centimeters which is gained with use of gender-affirming hormones is a little bit more limited. And these are the final heights, and that's also important because many trans adolescents are very worried about final height. If your registered sex is female and you want to continue as a male, you're afraid that you may be a little bit short as an adult, and the other way around for the trans girls. So we have analyzed final height as compared to predicted adult height and as compared to target height, which was then calculated for the sex registered at birth and also for the experienced gender. And what we saw was that actually the final height is very, very close to the target height for the sex registered at birth. And this is both for the trans boys and for the trans girls. So the target height for the sex registered at birth is really the best predictor of your final height. On the one hand, it's disappointing that we cannot improve height outcomes for our adolescents. On the other hand, it clearly shows that we don't really interfere with final height, and it's a safe medication in that respect. We also did some studies on body composition, again, for this very long duration of treatment. And this is also what we really expected to find. You see, if you use GnRH agonists for a long time, then you see an increase in fat mass. And this was both if you compare it for the pink, the female references, and if you compare it with the male references, both in trans girls and in trans boys. So the fat mass increases and your lean mass will decrease. And if we look at grip strength, then you see that grip strength in comparison to male references will decrease, whereas in comparison to female references, it will increase a little bit. Bone is always an important point of concern with use of GnRH agonists, and here also we confirmed actually what was found in other studies and showed that with such a long duration of GnRH agonists as monotherapy, you get a very important decrease in BMD Z-score. So the bone mass accrual, or the bone mass itself, remains constant. It's not a problem of loss of bone mass, but it's a problem of accrual of more bone mass, let's say, and therefore these Z-scores decline, and it's especially at the lumbar spine, much more than at the femoral neck, which you can see here below. And it's mainly the trans girls who are very vulnerable for this, because they already start with Z-scores which are well below 0 for other reasons than the medication, because it's already present at start of this medication. Reassuringly, there is a Dutch study that shows in a very large group of adolescents that afterwards, if you use gender-affirming hormones for 3 years or longer, that you will have a nice catch-up of these BMD Z-scores, which you can see here then. This is for the lumbar spine and for the femoral neck again. And especially in the trans boys, you get values again close to 0. In the trans girls, they remain a little bit below 0, but there is a clear improvement in these Z-scores. So why is it then that we are a little bit critical and criticized mainly also for using these GnRH agonists in the context of transgender healthcare? What we see is that transgender and gender diverse youth is really becoming a changing population and also a rapidly expanding population. This is a graph from the VU, from the Free University of Amsterdam, where you see that there is, since the year 2011, a very, very steep rise, and all this rise is accounted for by assigned females at birth, so trans boys, and they present at an age a little bit later than 10 years, usually around the age of 14, 15 years. And this is different from the population that we saw before, and it's exactly the same if we look at our numbers in Gent, and actually in many, many centers in Europe and other Western cities, for example, where you see that there is a very steep rise also at the Gent Gender Clinic for children aged 17 years or younger, but usually a little bit older than the ones who presented around 2007, 2010. In Ghent, this started very abruptly around the year of 2015, and there is also a complete swap in the sex ratios. So in 2007, 3 out of 4 adolescents who presented were trans girls, whereas now 3 out of 4 are actually trans boys. And what was also noticed is that at least half of them have at least one mental health comorbidity. So we have the impression, more than an impression actually, that this is really a changing population, but importantly, it's a very recent phenomenon, and we have no long-term outcome data. Of course, everyone can ask himself the question, where does this come from all of a sudden? What is the reason behind it, and will they really pursue this transgender path? But we really don't have these data currently. It's much too early. But it's important that if you look at the initial goal and purposes of the use of GnRH agonists as it was described in the Dutch protocol, which is like the basis of the use of this treatment, it says that one of the goals of it is to provide more time and more mental space to do a thorough diagnosis, to provide mental health support. And so during these years of mental quietness, let's say, the adolescents can think about if they want to pursue with this pathway. But if we look then afterwards at who will continue with these gender-affirming hormones, we see that almost 100% of those who started with GnRH agonists will continue with using the gender-affirming hormones. So increasingly, it is clear that it was first thought that GnRH agonists could function as a kind of pause button, but I think this is really a wrong way of presenting it to parents, to youngsters as well. So it's not a pause button, but an active step in the transition pathway. And so many questions are raised as are these transgender and gender diverse youth using GnRH agonists, are they kind of trapped in this pathway once they start? And can we also compare the kind of tsunami of youth presenting at our clinics with the initial group where this medication was designed for? So to conclude, we could say for CPP, we should always remember that early puberty is not really, in essence, a pathological condition, in many cases at least, and that the benefits of treatment are not always clear. So you should really go in discussion with your patient if he or she wants this treatment. It's case by case and in a shared decision-making process. For the growth promotion, it's an effective treatment, but it comes with a very high mental, physical and financial cost if you combine it with growth hormones, so we don't really do this. And for transgender healthcare, it's important that you realize as a pediatrician that if your adolescent, the family comes to you and ask for help, because these children are very often on a long waiting list for going to a child gender clinic, and they see their body changing, the puberty is starting, it's important that you don't start with prescribing the GnRH agonist already before there has been a thorough workup by a multidisciplinary expert team, because we really think that a diagnosis should be made by a child psychologist, child psychiatrist before GnRH agonists are started. And so with this, I would like to conclude and thank a lot of people, people from our team, all the BESPEED and the board for organizing this and for supporting us always, the researchers, Lloyd and Sylvia, our child gender team, also Daniel, who is with us already for a long time for doing this clinic together, and of course also the companies for supporting us here. Thank you very much.